Thanks for joining us, Dan. Tell us a little bit about what your role is.
Thank you for having me, Imo. My name's Dan Hughes. I'm a consultant psychiatrist that works with working age adults, primarily with diagnosis of SMI or serious mental illness. So that would incorporate illnesses like schizophrenia, bipolar affective disorder, severe depression. I also have a special interest in improving access for those with SMI to palliative care.
And tell me a bit about access to care, because I know, as a palliative care specialist myself, I know that often people with serious mental illness access palliative care less than, or end-of-life services less than other people in the population. Do you know what the reasons might be for that?
And there's lots and lots of reasons. I think the first thing to say is that people with a diagnosis of SMI have a significantly reduced life expectancy compared to the rest of the population.
Why is that?
They might die 15 to 20 years before people without an SMI. And lots of those reasons are matched with the question you ask about access to palliative care. So people are much more likely to present later with a diagnosis, so they might present with a stage 4 cancer rather than a stage 2 cancer. Often a phenomenon called diagnostic overshadowing may occur, which is where a clinician will see someone with an SMI who presents with a symptom or a number of symptoms, and that is presumed to be related to their mental illness rather than any physical cause. That can mean that, again, their diagnosis
They're missing things.
Yeah, it takes longer to make that physical health diagnosis. People with SMI might have quite complex relationships with healthcare systems, so they may well have been treated under section of the Mental Health Act in the past, which might mean that they have a certain view of healthcare providers, and that might influence how they interact with all healthcare providers, including primary care, palliative care, oncology, any physical health services. Some of the symptoms associated with illnesses such as schizophrenia may mean that people are paranoid or suspicious about those wanting to deliver care, and that can impact on how those patients might interact with services. I think it's also worth saying that people with SMI may engage in a different way to people without. Services might need to adapt how they offer their service to those patients.
So I know that often we talk about harder to reach patients, and there's definitely a culture now of thinking that actually these patients aren't so hard to reach, but maybe it's the healthcare professionals who are finding them harder to get to. What would your advice be about that?
Yeah, I think that's very, very accurate, really, that it might not be so much that patients are hard to reach, but that, as I said, we need to change how we approach those patients a little bit. I think the key thing is all those factors that I've just mentioned, taking them into consideration when approaching a person with an SMI. If someone doesn't respond to an opt-in letter, rather than just discharging them, thinking about whether there might be an alternative way that you could engage with that person. So that might be picking up the phone, calling them. It might be going to their home. It might be speaking to an important, a carer or a significant other for that person. It's also worth saying that those with SMI are less likely to have things like smartphones. They might not open their post. They might not have internet access, and all of that needs to feed into how you engage with someone. I also think that it is worth trying to find, if someone does have a community mental health team, for example, it is definitely worth speaking with them about how they've engaged with that person. So if someone has a community psychiatric nurse, they might say to you, there is no point in phoning that person or writing to that person. You're better off just to go around to their flat. And if you go around to their flat, then they're normally happy to speak, for example. Or it might be that actually it's a really good opportunity for some joined up working. Yeah. So if we think about the fact that, as I mentioned, people with SMI might have a certain view of healthcare services, and they might have some suspicion related to psychiatric symptoms to healthcare services. Well, actually, if the first time you met them, you went with someone who's been their community psychiatric nurse for 10 years, and that was a way of an introduction, that might help with engagement. So often it's about thinking outside the box a bit, thinking a bit laterally, and involving people that have prior knowledge of the patient. And all these things, are easy for me to sit here and say, but can be very difficult when we're in a high intensity, lots of referrals. So I think it's such an important population to try and reach and try and offer appropriate support to.
So that makes me think about the importance of co-working, particularly in palliative care, but in any specialty. If we have a patient with a serious mental illness who is in their last 12 months of life and deteriorating, what would your advice be to teams? And it could be any teams, it could be in physical health, they could be on a ward, they could be in the community, they could have had a long history. What do you think the best kind of care is, and how do we do that working together?
I think it's a really good question. It can be really difficult to secure those networks across specialties. And often that's because there's not a clear pathway for what mental health teams should be involved when a patient is in a different setting. So if someone is admitted to an acute hospital, then it's quite clear that if they need support with their mental health, then there's a mental health liaison team that will come and see the patient on the ward, offer support and advice. Obviously, if someone is in the community and they have a community mental health team, then again, that's easy. You can approach that community mental health team. But where it becomes more difficult is if a person doesn't have a community team, where do they get support from? And that person might have been stable for 20 years, managed in primary care. It might be that you're admitting someone to a hospice, for example. That can be really unclear as to who actually delivers psychiatric support to a hospice. It's not an acute setting, it's not a community setting. My advice from my experience is that it is just about making those local connections with people in your local community mental health teams, getting the phone numbers of friendly psychiatrists that you can phone up if you're stuck to get advice. And it's worth saying as well that it might not always be that patient needs to be seen by a mental health team or seen by a psychiatrist. It might just be about getting some telephone advice. And I think what's really great about that is that then works both ways, because when, as a psychiatrist, if I feel like I don't know how to manage or what might be best for someone's end of life diagnosis, I then have those connections where I can get support or work out where a referral is best placed. Mental health services are famously difficult to navigate, even when you're inside that system, let alone from outside. So often it is worth just finding someone to speak to and say, well, actually, where is this person best placed?
Dan, I wanted to ask you about how we might recognise when someone might be in their last 12 months of life, because death and dying isn't just the last few weeks and days, it is the last 12 months. So how, considering what you've said about how serious mental illness can make some physical illness a bit foggy in terms of recognition, what would your advice be to practitioners working in mental health about recognising those patients?
I think it can be really difficult, and I think that it's again where that joint up working becomes really important, actually, and involving primary care, palliative care, any physical health clinicians working with our patients to support us in recognising them, because I think it's something that we find difficult and we're not trained to do.
And can you think of any patients where there's been signs, or maybe more obvious in physical health, but things that you might be picking up on, eating less, sleeping more, general deterioration, that could be seen as someone being low mood, but actually potentially is physical deterioration?
And that's really difficult. So I mentioned diagnostic overshadowing, and I really think that works both ways. So as a mental health clinician, I think we have a tendency to think of, reduced sleep, low energy, fatigue, loss of interest in daily activities as being psychiatric symptoms, whereas, as you say, they may well be due to a deteriorating physical illness. And that, in my view, is about training, recognition, making sure mental health clinicians are aware to look out for these things in our patients.
Can you tell me about a patient that you have had in the past who was in their last year or months of life, and some of the experiences that you had in caring for them?
So I've looked after a number of patients in what's called a community rehabilitation unit who have a palliative diagnosis. And actually, that can be really, really difficult for mental health staff to manage, because there can be a lot of anxiety around physical health medication, and the dying process overall. So I think it was someone in particular who had a stoma and was constipated and needed enema prescribed, and actually finding someone who felt able to give that enema in this particular setting was really difficult.
Mm-hmm.
I think there's also lots of places where the systems that we have set up, such as DNA CPRs, don't apply or might not apply in the same way. So in this example, it was really unclear.
Resuscitation status.
Yeah, resuscitation status, whether it applied in this setting, and what the nurses on this unit should be doing if this person was to have an arrest. And again, that was really anxiety-provoking and really difficult for staff. And what actually worked really well in the end is the involvement of a local palliative care specialist nurse who came to the unit, was able to support us in delivering end-of-life care to this patient. And that was hugely reassuring to the team. Meant that we had someone that we knew we could phone if we were stuck or didn't know what we should be doing. But I think it was also really reassuring to the patient to have that person's involvement. So in the end, I think we worked really well together, but there was a lot of anxiety getting to that.
And some might say that in psychiatry you're very used to talking to people about their feelings, and therefore you would be the perfect people to talk about dying and looking after people at end of life. Can you tell me a little bit about where you think those skills cross over, and what the fears might be, and what confidence you think is needed for people working in mental health?
I mean, I agree. I think mental health clinicians should be or would be extremely good at talking to people about dying. If you think about how we approach suicide and risk assessment, it's actually something that we talk about really frequently with our patients, but that is in a particular domain. I think what we're not used to doing so much is talking to our patients about expected death from physical health causes. And I think it's something that we probably need more confidence in, more experience in, because I agree with you. I think a lot of the skills that we have lend themselves well to that domain.
Dan, I'd like to talk to you about prescribing. So with people who are in their last year of life, they might be suffering from pain, or they might have other symptoms that need to be medicated, and it can be tricky to know how to treat things when someone is also on other medications. What's your experience and your advice about that?
The most important thing is that any treatment plan is personalised and taken into account their views, but also any risks associated with changing or stopping treatment. So, a common situation might be someone with a chronic psychotic illness might be on long-term antipsychotic medication. That might be in a depot or IM, intramuscular form. Mm-hmm. And the question that comes up all the time is, as someone approaches the end of life, what do we do about that? Do we stop it? Do we carry it on? And I'm not sure there's a yes or no answer. It really, really depends on the situation. But the things I'd be thinking about were, well, what's the risk in terms of relapse if you were to stop or change that medication?
And what are the risks if someone's been on that medication for 20 years? And for example, as we know, in the last sort of days of life, people often lose their ability to swallow, so they can't receive oral medication anymore. If someone was in that position and then couldn't receive their oral psychiatric medication, what would you advise?
I think it really does depend on the individual patient. And this is where having a mental health team or a psychiatrist that you can talk to about the specific patient is really useful. I guess ultimately the last thing you want to do as someone approaches the end of life is cause that person to have a psychotic relapse. So that needs to be taken into consideration. But also if it's in the final days, the risk of that might be very slim. You might be able to manage any symptoms with medications that you're anticipatory medications that you're giving anyway for end-of-life care. So
injectable forms?
Yeah.
Or using benzodiazepine for agitation. If someone is agitated, then we could use the same drugs that we might be using for terminal agitation.
Yes.
To palliate the symptoms of a psychiatric agitation.
Or it might be that you're using an antipsychotic. So olanzapine, for example, is frequently used for nausea. It might be that you might be able to switch the antipsychotic to olanzapine if you're giving it for nausea anyway. So it's just worth kind of involving mental health teams in those decisions, really.
In terms of treatment for someone who is end of life, resuscitation is also a treatment, and the decision not to resuscitate can be a tricky one. What's your advice? Because I know that in palliative care we feel more confident about those conversations because we have them frequently, but in psychiatry my sense is that people are less used to having those conversations and less confident at knowing when the right time might be for someone not to be resuscitated. What's your experience, or what are your thoughts around that?
Yeah, I think you're right. I think it's something that we in mental health settings find quite difficult. We probably don't think about it enough. I think we should be thinking about it more. Ultimately, I guess it's an area that we probably don't feel experienced in to make the right decision about that, or at least don't feel confident in making that decision, because it's not something we do very often. And I would just come back to, again, it's about those reciprocal relationships with people from palliative care colleagues, so seeking support, but having it as an active thought in your mind that needs to be discussed with patients who have palliative diagnoses, making plans, but particularly for people that are in inpatient psychiatric settings where, if someone was to have cardiac arrest, there would be a response team and people prepared to give resuscitation, and actually thinking, well, is this appropriate?
Yeah.
Should we be doing this? Having those conversations with family members and having those conversations with patients as well.
And that brings me on to capacity, which is a challenging conversation, isn't it? For DNA CPR, we don't need the patient to have full capacity, but we need to have had the conversation, if they don't, with a family member. Can you give examples of the need for mental capacity assessment in psychiatry with people who are in their last weeks, months of life?
I mean, there's kind of extremes. I imagine most capacity difficulties that arise are in a kind of middle area. I mean, the extreme would be the patient with a cancer who is has a psychotic illness and is refusing an operation that could
improve their quality of
life, but they're refusing, and that might be because of, I don't know, delusional belief about the cancer or about the surgeons wanting to do the operation. And for those, I think it always involve a psychiatrist. I would say people need to be talking to their seniors, the legal teams in the hospital, their defence unions, etc., because I think they're really complex, difficult decisions, and you need to involve as many people as possible in making those decisions. I think a lot of capacity assessments sit more in a grey area, and it is worth saying that capacity assessments is something that everyone in health and social care should and could be doing.
Yeah.
For lots of those decisions, you wouldn't necessarily need to involve a psychiatrist.
I want to talk a little bit about what can happen when someone's coming to the end of their life. It's not unusual for people to become down and sad, which could be seen as an appropriate response to the fact that their life is coming to an end. And I want to ask you about that, and then when someone might become suicidal and how you manage that, how someone might manage that with someone who has a history of a serious mental illness. Where do we see that as a normal response to dying, and where should we worry, and possibly where do we intervene?
Yeah, it's really difficult to kind of identify depression in an end-of-life population. When you look at the literature, the rates of depression vary from 3% to 80%. And I think that really is a result of the fact that we struggle knowing where to define where people are appropriately sad that their life is coming to an end, and when does that cross a line to being depressed. And what makes it more complicated is that lots of the symptoms that we would look for in depression, so low energy, poor sleep, the so-called biological symptoms of depression
Are happening anyway.
Yeah. And so it might be that we look more for psychological symptoms of depression, things like hopelessness, worthlessness, but it can be really, really difficult to identify depression. I think it's about having an open mind and considering it as a starting point.
And being able to have the conversation without fearing someone talking about dying, I think is really important, isn't it?
Yeah.
And as a healthcare professional, being comfortable with talking about someone dying and not trying to make them feel better is important, isn't
Absolutely. And I think to lead on, you said that you asked about suicide risk. And my view would be that, that sits on a spectrum of sorts. So at one end you have people who have a wish to hasten their death. And then at the other end you have people who are actively suicidal, planning on ending their life by suicide. And really the only way that you're going to know where someone sits on that spectrum is by asking them about it, which can be really difficult. And particularly if you're not used to asking people about suicidal thoughts. I think what's really important to note is that all the evidence, including evidence for end-of-life patients, shows that asking someone about whether they're feeling suicidal does not increase their risk. It actually,
really important.
It actually reduces their risk.
So just talking about it is therapeutic in itself.
Yeah. And I think, again, palliative care clinicians might feel they have to have a special skill set to be able to ask these questions. Actually, I think a lot of what palliative care clinicians do aligns really nicely to doing a comprehensive risk assessment in terms of thinking about suicidal risk. It's about empowering those clinicians to feel confident in doing it.
And if you're not in a psychiatric setting, if you're in the community and you are worried that someone is becoming suicidal, what would you do? Would you be contacting the local mental health team for support?
Yeah.
A crisis team, perhaps?
Yeah, so all areas will have a 24-hour crisis line and that will have clinicians that you can speak with for support and advice. If you're really worried about someone's risk, bring them to the emergency department where they can see a environmental health liaison team. But I think that should be seen as a last resort, really.
But good to know if there's nothing else, there is a place to take them where they can be seen.
I think it's important to also highlight that suicide risk in a palliative population is, generally speaking, low. And that's across different settings, so in acute hospital settings, at home and in hospices. Completed suicide is fortunately relatively rare, and that's despite things like access to lots of drugs that could be potentially lethal in overdose. So I think that's important to highlight.
I'd like to talk about something that I'm hearing a lot, which is trauma-informed care. Maybe you can tell me a little bit more about that, but also how we can apply that to looking after this patient group.
I mean, it's so important to consider in this patient group. So many patients with SMI have experienced traumatic experiences at some point in their life, often during childhood. And what's important to remember is that as you approach the end of life, I mean, you can imagine there are many experiences that are part of that may be re-traumatizing for people.
Like personal care, like being washed, intimate care in bed if you're unable to wash yourself, I imagine might be triggering if you've been sexually abused, for example.
Yeah, or just the act of being admitted to a hospital ward with other people who may be distressed, shouting out,
Right.
maybe re-traumatizing for people. So it's really important to consider that, and that both palliative and psychiatric care is delivered in a trauma-informed manner.
And what, just in a nutshell, what is trauma-informed care?
It's planning the way you deliver care, thinking about what traumatic experiences people might have had in their lives. The first step is simply asking people about trauma and whether they have experienced trauma in the past. You may not have to or be able to go into any detail about that.
Right.
But it's starting that conversation.
And not being afraid to. I might feel worried about re-traumatizing someone if I ask about their trauma.
Yeah.
But would you say that it's a better idea to ask?
Well, I think it's
question?
about being led by them. So
Yeah.
if someone very clearly doesn't want to talk about any trauma that they've experienced, then I think you follow that. And also, recognising the situation that you're talking about trauma. So if you see someone in an emergency department, you've got 2 minutes. It's not appropriate, obviously, to say, and has there been any trauma? Yes or no, tick.
Mm-hmm.
But I think, where you've developed a relationship with someone where you have some more time and where it feels pertinent, that's when it's important to start gently exploring these issues.
And this brings me back to what we talked about at the beginning, which was that this patient group can be harder to reach.
Mm.
And this is possibly why these patients are harder to reach, because they have experienced trauma and therefore they're less willing to engage with people because of trust issues.
Yep.
So it makes sense.
Yeah, trauma can be all-encompassing in terms of the way that it shapes our relationship with others. And those others can be our loved ones, our friends, but it can also be the people delivering healthcare.
Can I ask you also about, towards end of life, in my experience, people often have what can be known as existential crises or experience existential pain, which is really kind of psychological pain of what they might have remembered in their lives, things that come up in their experiences, things that they might have put away that tend to sort of re-emerge towards the end of life. Does that happen with patients who have experienced trauma?
Absolutely, yeah. You might be in that process, in that dying process, you might be considering how you say goodbye to someone, goodbye to a family member. And if that family member has somehow been involved in a traumatic experience in your past, or even if that family member was, someone who wasn't aware of the trauma, that creates a difficulty in that goodbye. And so absolutely that can be really important to consider.
Thank you. Thanks so much for joining us. I think what I've taken from this conversation is that actually there's a lot of skills that are quite similar in psychiatry and in palliative care. What would be great is for our healthcare professionals within mental health to feel that they actually are more able than they might feel they are currently. They have the skills just to expand them and start talking about death and dying a little bit more, to not be afraid of that. But thanks so much for joining us and sharing your knowledge.
Pleasure. Thanks for having me.